this breast cancer management history from maximum to minimum. I was asked one day a question: is breast cancer a medical oncology issue or a surgical one? Really, I had to think a lot. What am I going to say about it? So just my answer in brief was, well, without surgical input, hardly any long-term survival. But without medical input, no improved survival. What is that? Let's go back, talk about the evolution of breast cancer management. Breast cancer was mentioned at the time of the pharaohs, and they used to call it the bulging tumor, but no management whatsoever was proposed for it. We had Hippocrates, we had Galen over the years. They all describe it as the oozing disease. Galen called it the crab, meaning the saratan or kaburia, because whenever they cut it, they saw blood vessels branching away from it. This is where they called it cancer, and why they called it cancer. But again, there was just palliative management, sulfur, opium, just pain management. No surgical or medical intervention ever. But then we started from the time of William Halsted. We all know William Halsted in 1890, when he advocated the radical mastectomy, where he removed the breast, the pectoralis major, all the levels, the 3 levels of the axilla, all en bloc. It was really important because that guy really taught us the en bloc excision, the principle of not contaminating the field to avoid any local recurrence. And he really did improve local recurrence, but with a mutilating surgery. Actually, even Veronesi, the famous Italian surgeon, he advocated even removing the internal mammary nodes. But that again was really very aggressive management. They even did shoulder disarticulation. We all know Petty mastectomy, where he said, don't remove the pectoralis major because it causes a lot of deformity, but let's remove just the pectoralis minor. And then we did the modified Petty, just or disconnect the insertion of the pectoralis minor, and then you can go behind it and remove level 2 and level 3 nodes easier. And then we started talking modified radical. Don't remove any muscle, just remove the breast and lymph nodes. And that continued until 1974, when the famous Bernard Fisher in 1976, when he said, come on guys, we really have to get in with some medical treatment instead of these very mutilating types of surgery. And he advocated that if you remove just the tumor, plus or minus the lymph nodes, and give radiotherapy to the remaining breast, will be as good as having done mastectomy. And that really has been the case. That was a change completely in 1976, from radical surgery to breast conservation over the last 44 years. And then we started to discover the contraceptive pill, the tamoxifen, and has been well in use over the last 30 to 40 years. Survival started to improve. So actually, when we got in with the medical treatment, survival improved. But see that moving from maximum surgery, radical surgery, to breast conservation actually did not reduce survival. Survival remained the same. So we moved from maximum to minimum, from radical surgery to conservation. The survival did not go down, actually it remained static. But the improvement here was in survival by introducing some medical treatment in between radiotherapy and adjuvant medical treatment. So that was the end of Halsted. So we started to talk multidisciplinary approach. In 1990, we started to talk about neoadjuvant chemotherapy. We started to see the importance of having a dedicated pathologist who can really give us the best possible data that will influence our management. We needed a surgeon, we needed a dedicated radiologist who will guide us through management, all steps. We needed a breast care nurse. Without a breast care nurse, you really are crippled. is 50% of your power. You need a breast care nurse, dedicated breast care nurse. So continued advances in medical management really was leading to significant increase in overall survival. Again, we have the tamoxifen. Now we have also the aromatase inhibitors. We all know Femara. We all know aromazine. We all know Arimidex. So we really, a lot of changes, improvement, and all adding to the improved survival over what we gained from surgery. Chemotherapeutic regimes for the AC, the FEC, the taxane, the Herceptin, the Perjeta, Oncotype DX, response modulators. Whenever you have a hormone receptor positive disease that becomes resistant, can you modulate the response again to get it back in line to respond to medical treatment? Radiation therapy has changed again completely. It helped us moving from radical surgery, mastectomy, to can conserve the breast. Actually, you can even irradiate the axilla without having to remove any lymph nodes if you have to. So again, that was really important to us. So we continue to know more and more about breast cancer management. So we developed the multidisciplinary teams. We advocated the one-stop clinic where patients come in right now, have all the investigation under one roof, which I hope it will be available almost in every district, not just in every city. The patient comes right now to be examined, have the mammogram now, be told the results of her mammogram right now. If biopsy is needed, it is taken right now, and within 48 hours, you will have all the results instead of the weeks and weeks of waiting to know what do I have? Do I have benign or cancer? We really need these one-stop clinics everywhere. I'm just running through as an introduction to breast cancer management today, and then over the next weeks, as often as you want, we can go into more and more in depth in whatever management step we need. Where are we now? The chemotherapy now, over the last 30 years, has become an integral part of breast cancer management since the 90s. Even we are using it as upfront in neoadjuvant chemotherapy. It improved survival over what we have gained from surgery. We are using it upfront as a neoadjuvant chemotherapy. Why? The indication for upfront chemotherapy as a neoadjuvant chemotherapy, NEO, is to make inoperable operable, and to make only solution is a mastectomy, so we can reduce the size and can go for conservation instead of mastectomy. And again, we're testing new drugs, and nowadays, actually, you can transform axillary clearance into sentinel nodes, so to reduce the morbidity from axillary dissection. You know, with the improvement in medical management over surgery, the attention of the surgeons became, can we reduce the morbidity from surgery? Okay, we cut a lot, we cut less, survival is the same, we're improving it with the medical treatment. So what we can do as surgeons, we started to say, can we reduce the morbidity? What is the morbidity here from surgery? It is the disfigurement from surgery, the mutilating mastectomy, the disfigured breast that we leave behind, and the lymphedema. So surgeons started to really pay attention to these things, reducing morbidity, the deformity. So we started to get in with the oncoplasty. We're using the plastic surgical techniques to help us become very aggressive, and I'm going to touch it in a minute. Who needs chemotherapy? When you are in your clinic as a surgeon and you have a patient with breast cancer, you've done everything. Now we need to know what, does he need chemotherapy or not? I always tell every surgeon, pay attention to 6 points. I'm going to mention them now. 6 points. If you find 2 of them exist already in this patient before even you start the management, get the opinion of a medical oncologist, because they might benefit from chemotherapy upfront. So if you know from the very beginning they will need chemotherapy, you might as well go and get the attention or the opinion of a medical oncologist. Should I give her the chemotherapy before? Will it help my type of surgery or not. So what are these 6 points? If the 2 or 3, the more of these points exist in a patient, the more likely that she will definitely need chemotherapy. If she's premenopausal, that's a bad point. If the size of the tumor is more than 2 centimeters, it's also an important point. If it is grade 3 and you already know from the core biopsy, it is an important point. Lymph node involvement. If you have a patient with clinically or radiologically have affected lymph nodes, that might be an indication to that she will need chemotherapy. And then you start to ask yourself, should I give it before or after? And again, the ER negative tumor, it's a bad point, and the HER2 positive disease also is a bad point. So if you find 2 of them from the very beginning, before you start the treatment, exist in this patient, then you know that she will benefit from chemotherapy. You have to ask yourself the second question, should I give her the chemotherapy upfront or should I give it after surgery? So this is very important. Again, radiotherapy has helped us a lot. Any breast conservation will benefit from radiotherapy, as we said when Bernard Fisher in 1976 proved it. If I did mastectomy, you don't need to give chemotherapy, radiotherapy, except if they have any number of nodes involved, then even if you did a mastectomy, they will benefit from radiotherapy. If you have a positive margin and you cannot go back in again, and if it is T4 tumor before you did the operation, if like inflammatory breast cancer or fungating, ulcerating, fixed tumor, even if you did a mastectomy, they will benefit from radiotherapy. Knowing all these in advance for you as a surgeon will help you plan management. Because if you knew already she will benefit from radiotherapy, do you really want to talk reconstruction with this patient up front, and the radiotherapy will burn it off for you and will really change the final cosmetic outcome? It will really guide you. So it's important for you as a surgeon from the very beginning to know who's likely to benefit from chemotherapy and who's likely to benefit from radiotherapy. Should I give her chemotherapy up front? Should I change the type of surgery because she will need a radiotherapy? These are very important points for you. I'm going to stop here and then we go back to very important points. When you examine a patient in the clinic, please take a history and pay attention to 4 cardinal symptoms. These patients actually, you have to ask, what is the leading presentation by this patient? A lump, pain, discharge, or I have a family history and I'm concerned about my risks of developing cancer. So if she has a lump, pain, or discharge, you have to specify which side, because if you send and document the wrong side in your form, it really will be very confusing for the radiologist and for you on the day of surgery. So document the side. You have to ask about the history of trauma, because there's fat necrosis that will cause a lump. There's a hematoma that will cause a lump. Actually, trivial hematoma in the presence of a tumor. Tumors with a slight trauma can lead to hematoma. So don't get misled and consider it just hematoma and that's it, because tumors are very vascular and any trauma near them will cause a lot of bleeding. So watch out that patient who had an accident, had a hematoma in her breast, watch her carefully because she could have underlying breast cancer. So these are important points: the duration, the contralaterality. When you talk about pain, you have to specify whether it is cyclical or non-cyclical. When you have discharge, you have to document is it spontaneous or not spontaneous, because that will make a difference to your management. We're going to talk in future lectures about all these in details, but I'm just running through everything. And again, you have to know whether it's blood stained or not, because that again will change your management. Family history, there's nothing called just family history. I have one of my neighbors, my great-great-grandmother had had breast cancer, then I have a history of breast cancer. No, I have a family history. No, it is not. You really pay attention to 3 points. The degree of relation, mother and sister and father are different from auntie, grandmother, different from my cousin. So first degree, different from second degree. The age of the relative, when she had the breast cancer, was she under 40 or over 40? Under 40, there's a good chance as high as 30% could be genetic, but over 40, don't forget that breast cancer is an aging type of cancer. Again, so the age, the degree of relation, and pay attention to the number. Okay, I have one auntie, she's second degree, but two aunties and a grandmother. The number here will prevail, and then also pay attention when the number of the relatives, even if they are second degree, increase. But just don't say, my grandmother at the age of 60 had breast cancer, I have a family history. No, that's not a family history. So these are important points. Again, examination, we really pay attention. Please never ever use the tip of your finger examining the breast. Please, inspection when they are sitting up, and then whenever you examine, it is the flat part of your fingers, not the palm, not the tip. It's the flat part, and anything rolls under your finger. This is what's significant, because we unfortunately make lots of mistakes, our younger colleagues, using the tips of their fingers. No, don't ever do that, because it's very misleading. And then, again, the medical history is really important. The medical history might not help you diagnose, but it will help you plan management. Imagine a patient is insulin-dependent diabetic, and you want to talk to her about skin sparing, nipple sparing, mastectomy. Complications are going to be very high in this situation, to be very careful. Again, systemic lupus erythematosus, SLE, or connective tissue disorders could really ruin any reconstruction. It might be a relative contraindication, if not absolute contraindication, to do reconstruction. Smoking will really, really affect your reconstruction. So knowing a patient on anticoagulants, you really want to take core biopsy in your clinic while she's on anticoagulant, she'll be oozing blood on you. So really be careful, pay attention to medical history. A patient had a TIAs, transient ischemic attacks, or a stroke over the last year. Do you want to give her tamoxifen as adjuvant therapy, which increases the DVT and the stroke incidences? So be very careful when you talk. So take history of strokes, history of connective tissue disorders, smoking, diabetes. It's very important. Whenever we're going to investigate, what investigation? Generally, mammogram is the workhorse of investigation, but it is suitable for over 35. Under 35, usually ultrasound is good enough. But you can go for an MRI. When are we going to go for an MRI? Unfortunately, lots of people go right away now for MRI for the patient. I think we have to be careful. Cost-effective therapy is really important nowadays. MRI is to solve a problem. I have discrepancy between the mammogram and the ultrasound and the clinical examination. There is discrepancy. Mammogram says 5 centimeters, clinical by hand 2 centimeters. Then possibly the judge would be the MRI here. I have a patient who's 25, not suitable for mammogram, and she has a very strong family history. Then I'm going to get an MRI, and so on. So MRI is really never ever the first line of investigation. It is there to solve a problem that you cannot solve by just mammogram and clinical examination. These are important points in investigation. What about FNA core biopsy? Tissue diagnosis is mandatory, please, and we're going to talk about it in a minute. Core biopsy is mandatory. Let me get back to you in just a second. Why do we say core biopsy is mandatory? FNA, yes, it will give you some hint about whether there are suspicious cells or not, but it is never going to tell you exactly what type of cancer, because there's a big difference here between management of invasive lobular carcinoma and ductal carcinoma, between invasive cancer and ductal carcinoma in situ. Am I going to remove lymph nodes in ductal carcinoma in situ because the FNA was positive? So you really, FNA, don't ever use it. And please, in Western world, you'll be taken to court if you do mastectomy based on an FNA. So never, ever, ever operate on an FNA, except in two situations we can use the FNA. First, a patient who is on anticoagulants. I cannot take a core biopsy from her today. I'm going to stop the anticoagulants, get her back in 5-7 days, then I can take a core biopsy. I can do an FNA today, will give me preliminary results by the time I get to do the core biopsy. So FNA is really obsolete. Please don't ever rely on it. Again, you might use it for a patient who is 20, clinically and radiologically fibroadenoma. Fair enough, you can do an FNA here instead of core, but mainly for patients on anticoagulants. Core biopsy is mandatory. It is sad that we still see people doing excision biopsies. It is crime to do excision biopsy of a tumor. It is a crime. Core biopsy is mandatory. Why is that? Core biopsy will tell me what type of cancer, lobular, ductal, DCIS, or invasive. What are the receptors? Am I going to give her chemotherapy upfront or after surgery? So it's mandatory to really do a core biopsy. And I'm proud of all my colleagues in Al Fayoum General Hospital because they all do core biopsies there. And I hope they're still continuing it. So please, nothing called excision biopsy. Hello.
الو الو
الو
خلاص معاك يا فندم. دكتوره زهره، في حد فتح اسمه ايمان طوخي فاتح المايك. دكتوره ايمان طوخي فاتحه المايك، تقفله او اقفليه انت يا دكتوره زهره من عندك. دكتوره ايمان طوخي اقفليه من عندك يا دكتوره.
يا دكتور طاهر.
احنا سامعينك يا باشا، بس في الخلفيه بس حد فتح المايك كده، هنخليه يقفله عشان نسمع حضرتك الون بس.
So we talked about importance of core biopsy. Excision biopsy, when you get a patient having had a excision biopsy, assuming it is benign, and then you get a positive margin, and then you need to take the
زهره لو
patient back
سمحت
to theater.
اقفلي على دكتوره ايمان عشان الصوت بايظ خالص.
You need to take the patient back to theater because someone not responsible enough has done an excision biopsy instead of a core biopsy. They tell the patient that core biopsy causes spread, but excision biopsy does not cause spread. And then the patient comes back with cancer. It is cancer. You need to take the patient back to take a better margin. You need to take the central lymph node. The patient will pay the price financially and price from their health and the anxiety that is involved with a second operation. So please refrain from excision biopsy. It is a core biopsy. It is mandatory. The only contraindication is a patient on anticoagulants until you stop it. So now you have assessed the patient. I just want to touch here. Some people do a staging from the very beginning. What staging do we need for breast cancer here? The basic staging is full blood count, kidney function, and you need to know the liver function and bone profile, and possibly plain chest X-ray. But we see people going straight for PET CT scan almost before they even get the core biopsy result. And that's really, really bad practice. We have to be cost effective here. What are the indications for further staging apart from plain chest X-ray, full blood count, kidney function, and liver function here? What else? CT scan, bone scan, or PET CT scan? Only if the tumor is T3 or T4, more than 5 centimeters T3, or fixed tumor like inflammatory breast cancer, ulcerated T4, or matted lymph nodes, and not N2 or N3. These are the cases you might request upfront CT scan, but otherwise, please, it does not add anything. Is there any difference between CT scan and bone scan? Does bone scan add to the CT scan? Absolutely very little, because CT scan is superior, and we've done these studies to detecting bone metastasis. CT scan, yes, it is superior to bone scan. Only get a bone scan if the CT scan shows a vertebrae or a rib that show tumor. Hang on. But what about if you have a tumor in the tibia, in the long bone? You will never see a tumor in a long bone that without having a vertebrae or ilium or rib involved first. It does not happen. of course, unless it is symptomatic, then enough, you can get a bone scan. The patient has localized right leg pain, then fair enough, get a bone scan. But CT scan is enough. PET CT scan is extremely expensive investigation. Sometimes whenever the technology gets advanced, actually can go in circles because it is extremely sensitive. So a CT scan be cost effective only if you have a T3 tumor or if you have a fixed tumor like T4, recurrent cancer, or massive axillary lymph nodes. None of these, please, no indication for CT upfront staging. But you might do it post-surgery if you have 4 nodes or more involved, or prove that the final size of a tumor is more than 5 centimeters, then fair enough, you can order it post-surgery. But upfront, please, T3, T4, and recurrent breast cancer and massive lymph nodes. These are the only indications for upfront staging, please. We go back now to, okay, now management, as we said, see which patient will benefit from chemotherapy.
Dr. Ashraf?
Sorry, somebody wants to say something? Yeah?
We stopped sharing screen. Is it okay?
I will get it back to you right now.
Okay.
I'll get it back to you. Is it back now?
I think, yes.
Is the share screen back now?
Yes, Dr. Ashraf, yes, we can see you. Share screen, yeah.
Okay. So I'm sorry that I actually deliberately stopped it because I wanted to talk a little about investigations and history taking and planning. So please plan management upfront. Not every patient is straight for surgery. You need to see which patient will need chemotherapy, which patient will benefit from radiotherapy. They will modify your management plan. If you have many points that points to she will need chemotherapy, get the opinion of a medical oncologist. They might benefit from upfront management. Surgery here, as we said, with improved survival, now we are paying attention to reducing the morbidity. So where are we now? We're doing far less mastectomy than once we did, maybe 20 years ago. I've been a consultant breast surgeon for the last 23 years. We did about 60% mastectomy in Britain. Nowadays, we do only 20% mastectomy over there. We do more lumpectomies. We're doing a lot of oncoplasty. We're doing reconstruction. In the past, we used to ask for a margin when you excise a tumor to be 10 millimeter or more. Nowadays, for an invasive tumor, not at the ink margin is good enough for us. Even focal involvement in one slide, we accept it and radiotherapy will take care of it. But for DCIS, we always still stick to 2 millimeter margin for the DCIS. And we can talk, we have lectures to talk about specifics about DCIS, special types of cancer, invasive lobular. We can talk about it later. But today we're just having a run over everything. We're doing more prophylactic mastectomies. We all know the Angelina Jolie phenomena when she was diagnosed with BRCA positive disease. She asked for bilateral mastectomy and eventually bilateral ovarectomy. And that really caused a lot of increase in people requesting prophylactic mastectomy. And again, I stop here and say, every patient who had breast cancer in one side have the right at any time to request prophylactic mastectomy in the contralateral side without referring her to a psychiatrist. But when you get a patient who has no family history, but just wants to have a prophylactic mastectomy, never without getting the assessment of a psychiatrist to make sure she's well aware of it. But if she's a BRCA positive, you're going to do a lot of counseling and genetic testing, and off you go, of course, for what type of mastectomy, and you pay attention to the ovaries as well in her case. We now know that LCIS, lobular carcinoma in situ, is different from ductal carcinoma in situ. It is not carcinoma anymore. That's why we changed its name to lobular neoplasia, LCIS. DCIS is a type of cancer that cannot spread. LCIS is not. Its existence in the breast means this patient is at a higher risk than other women at her age for developing breast cancer 50% of them will be on the contralateral side, and 50% of them will be ductal, not lobular. So it is prognostic, not diagnostic, and you don't have to excise the lobular carcinoma and sit you in a core biopsy, unless, of course, it presented as a lump. Multifocality, it used to be multifocal, you have to do mastectomy, multicenteric even. Nowadays, we can conserve at the era of oncoplasty and does not compromise the survival of these patients. These are the changes of today. What's oncoplastic? People living longer and much younger. Oncoplasty was a way to help you as a surgeon to become a very active. So it's not a minimalistic as someone might think. Actually, it allows you, instead of getting a 1 millimeter margin, to have 10, 20 millimeter margin, and for the benefit of the patient, and still leaving her with an even better looking breast than before the operation. And when you do that, you get a very good margin, much better possibly local recurrence statistics, and the patient will be accepting adjuvant therapy more because she found it not mutilating, so why not carry on with other forms of treatment? So it's all using plastic surgery. When you don't have the experience of doing plastic surgery, you get the service of a plastic surgeon. Eventually, you will learn some basics, and we're going to have a lecture just how to use very simple approaches from plastic surgery for you as a breast surgeon, general breast surgeon, to benefit. And you'll find there are few techniques that you can apply almost to 80% of your cases, and you end with excellent oncology results and excellent cosmetic outcomes. Again, you don't want to leave your patients as deformed as we can see now. It's not very nice. So if you pay attention to the direction of your incisions, to how you close, you can see here in this specific patients, if they close the parenchyma, this patient definitely would not have had this deformity after radiotherapy, because if you allow the skin to see the muscle after surgery, there is affinity and will always, after radiotherapy, go straight down and stick itself to the muscles. So please pay attention to clothing the deeper layers. Right. So this is just a picture of how what you don't want to see in a patient. Right, again, oncoplasty helps you become very aggressive. These patients I have operated on over the years, you can see a white patient with massive tumor in the breast and massive writing on her clavicle. And she's young, she's in her 30s. Are you going to leave her to die in this way with that horrible about to fungate and ulcerate? As you can see here, it's horrible. So you can excise it. You just give her some palliation. And even if she's going to die in 6 months or a year, not with a fungation, bleeding, ulceration, infection there. And if you learn how to do an LD flap, you can close such a wound. Another patient with horrible ulcerated, fungated, infected, she's 72. Can you leave her this way? Absolutely not. But you can excise. Can you excise? You cannot close. So you can do a simple LD flap here. You excise it, and this patient really she was very, very grateful that she got rid of all this infection. So this is oncoplasty. Another patient, you can see here, there is ptosis. Usually nipples should be where the two breasts meet, but she has a lot of ptosis, and this patient had 2 tumors at the inferior pole, and we did a reduction mammoplasty technique for her. Actually, we were going for 1 tumor. The histology showed 2 tumors, not 1. So oncoplasty allowed us to get a very clear margin, even found an incidental second tumor there, and the margins were well over 10 millimeter, and she's much happier with her breast lifted with the nipple nicely lifted over there. So these are examples. Another patient here, who had very big area of DCIS here. We excised it, we removed them, we lifted up the nipples to that level. We managed to get a very good clearance for the good benefit of the patient instead of mastectomy. So this is the importance of learning a bit of oncoplasty and a bit of reconstruction. What determines feasibility of reconstruction? Basically a surgeon and a suitable patient. What surgeon? You have to learn it. What are the patient's factors here? Be careful, and you have to know them while you're taking history. Diabetes mellitus, especially insulin dependent, be very careful about them. Connective tissue disorders, autoimmune diseases, systemic lupus erythematosus, any renal impairment, because when you move muscles around, you can affect the kidney function badly from autolysis of the muscle edges. Cardiac impairment, because you don't want really to affect the cardiac output, which will be important for the flap survival. High BMI, they're always prone to all sorts of complications. Smokers, please be very careful about them. Advise them to give up smoking because it affects the small vessels, which when you do flap, they rely on them. Even when you do a nipple sparing mastectomy, the vascularity of the nipple is very, very precarious, and you smoke after that and the nipple will go black immediately. Timing and stages, so either you do it immediately, which is the best cosmetic outcome, but not necessarily the best for the patient. Might be delayed. Yes, there's advantages and disadvantages. I don't want to talk a lot about them, but I will say immediate helps you preserve the envelope of the patient, get the best cosmetic outcome. It's all one cost, one pain, but hang on, you can rush the patient. The bigger the operation, the more complication, the more infection, which would delay a much needed chemotherapy. You like always to start chemotherapy within 35 days from the operation. But if you do a bigger operation and then it gets infected or flap loss, you cannot give chemotherapy until it heals, which could be 3 months later. Then you did not benefit the patient. So these are drawbacks of immediate reconstruction. Again, she might need radiotherapy, which will affect flaps, sometimes shrink. If you put an implant, the capsule around it can go very hard, which all would affect the final long-term outcome of the reconstruction. But delayed, yes, you will have assessed everything. You will have had all sorts of adjuvant therapy for this patient, but that means it is a second operation. You've already lost a much needed skin that you start after that, looking for it. Where am I going to get it from? Am I going to be able to expand here? Or I have to go for an autologous flap? So there are also disadvantages about it. But nowadays we can do what we call the immediate delayed. Immediate reconstruction, but don't put a flap, don't put an implant, just put an expander. And don't inflate it a lot. If this patient will need radiotherapy, you give radiotherapy everything, and then 6 months after radiotherapy, remove the expander and put the implant, or put your flap. And then nowadays, you're not going to irradiate it, so you're not going to lose it. So what you call it immediate delayed or delayed immediate is putting an expander, waiting. Few weeks later, you can change to complete reconstruction, or you wait until you finish radiotherapy and chemotherapy, so something in between. And I think it's very popular all over the world now, in this immediate delayed reconstruction. 1 stage or 2 stages. In reality, almost always need 2 stages, but we can always aim at 1 stage. What do you mean? Whenever you do reconstruction, you always need symmetrization of the other side, because if a patient has ptosis, you cannot reconstruct a ptosed breast. You will always reconstruct elevated breast, and you always need some adjustment on the other side. You need nipple reconstruction. You need a bit of lipomodeling here, a liposuction there to just get the perfect result, or a nipple reconstruction even. Timing, as we said, immediate or delayed. What form of reconstruction? To really build a ball, you need skin and a filling. When you do immediate, you have the skin, and then you can put whatever you like inside, implant or an autologous flap. But if I did a delayed, I really don't have skin. I really need to either expand the native skin with an expander or get a flap. So you have either implant or autologous. When I wrote here implant, subpectoral, but nowadays lots of people doing it prepectoral subcutaneous with the use of various types of meshes that like the ADM, tie loop, and so on. Or autologous, you get the pedicled or free flap. It is a muscle with the overlying fat and skin. The muscle is the surrogate for the overlying skin because it provides it with the blood supply. You can do it pedicled or free flap. Sometimes when you move an LD flap and it's not big enough to match the contralateral press, you can put with that autologous muscle a flap, an expander, or an implant to bring it to match the contralateral side. When we do mastectomy, you can go subcutaneous where you end just by a transverse line, or you can do skin sparing where you only excise the nipple areola, or you can do for nipple sparing where you don't excise anything, maybe a bit of skin over the tumor. So this subcutaneous mastectomy with and we put a delayed reconstruction for her. We put an expander, and she did very well. We put a permanent implant. She's called Pamela. I remember her very well from London. And whenever she had a party, she used to come to me before the party and say, "Can you inflate it a bit?" And then when she finishes the party, come and say, "Can you bring it down a bit?" So actually distracted her from cancer, and she was very happy. These are examples of free pedicled flaps. They look very good. And actually, they did not want to have any nipples anymore. They were quite happy with this. This is another one of them who had a nipple reconstruction on the left side. This is one with the example of a nipple reconstruction. We lost a bit of the right nipple, but it was very long, so we just lost the tip of it. So, as we said, it can be some complications. Axilla, we used to, as we said, verinose, we used to remove the internal mammaries, but now we're coming down and down. So we really have to ask ourselves, why do we remove axillary lymph nodes? Is it part of local management or part of just I want to know? So do we remove it as part of local regional recurrence control? Then possibly all patients should have complete removal of the nodes. All of them need clearance. If you consider the axilla as part of the local control, every patient should need clearance. But if it is just to know, then possibly just FNA might be enough for us. So really, nowadays we say, you have to decide, is it bad axilla? Do I have to do clearance? Or is it just information? It has been a long journey over the last 30 years about it. We moved from clearance level 3 to level 1 and 2 to sentinel node, and then we can proceed to clearance, or sentinel node and stop, don't proceed to clearance. And who needs to be that we, after sentinel node, proceed to clearance, and so on. So there's a lot I can talk about here, but that needs 2 or 3 hours lecture, but I'm just running through it. Right. So we have studies. The most famous one of them is the NSBBP04. That was started by Bernard Fisher. And he proved, interestingly, that he brought some patients who had clinically negative axilla. And he started to stratify them. Some of them had mastectomy and axillary clearance. And some of them had mastectomy with no axillary clearance, and some had mastectomy with irradiation to the axilla. And they followed these 3 groups of patients for 25 and 30 years and actually found no difference in survival. Hang on, but there's something wrong here. Actually, people who had mastectomy and clearance for a clinically negative axilla, about 17% of them had positive axilla. Then we have to assume that the others also had 17% positive axilla, but some of them did not have the axilla removed, and some of them did have radiation to the axilla, but the survival is the same. So we started to know that the lymph nodes are more information than it is actually mandatory to remove. So we started going less and less for the axilla. We realized that about 30% maximum of these patients who you carry on or carry out axillary clearance on them would have positive axilla. 70% will have negative axilla, but all will carry about 25% risk of lymphedema on the long term. So we started to pay attention after the first morbidity, the cosmetic. Now we're paying attention to the second morbidity, which is the axilla. Do we need the lymphedema? Can we save these patients, the 70% that will have clearance for nothing, for no gain, because it's a negative axilla? How can we identify them? Do we do level 1, 2, 3 clearance or not? So it was really journey over the last 3 years, since 1988, when Morton et al. They did for the melanoma, use the sentinel node, and the breast surgeon grabbed it and have been the standard ever since. Predictive factors. Whenever you have a clinically negative axilla and then you take a lymph node as a sentinel node and then it proves to be positive, do you really have to complete clearance or not? Again, we used to be in the past differentiate between up to 3 lymph nodes, 4 or 9 or more, but not anymore. 1 is just equal to 9 for us in real practice nowadays. So the number, when we say, if anyone remember the Nottingham Prognostic Index, NPI, in 1987, when they paid attention to the degree or grade of the tumor, the size of the tumor, and the lymph node, the number of involved lymph node. But at the time, they never paid attention to there was nothing called ER testing or HER2 testing or anything. So it's obsolete now, but lymph nodes and the number of lymph nodes involved was very important, but not anymore now. There are some studies, right? Is radiotherapy better at controlling the axilla, or is mandatory to do axillary clearance? There have been so many studies, starting with the NSBDP 04 by Bernard Fisher, until today, Amaris axillary mapping and radiation or surgery. And they both showed that radiotherapy is as good as axillary clearance. And we will talk about it later at a later date when we talk about axillary management in more details. Leave them now. They're not shall we do clearance? Central node now is a standard, please. Lots of people, I've been coming to Egypt since 2005 for the last 15 years. And I was begging people to do sentinel node, not clearance for every patient. And there were excuses. We need to learn. We don't have blue dye. We don't have technician. Hang on, blue dye now is available, and I'm prepared to provide you with any amount of blue dye at no cost. And it's now available in Egypt cheap. You can get 4 milliliters. And all you need to inject is less than 1 milliliter in the patient. You can get a 4 milliliter amount for about £400, or 2 milliliters for about £200. It will be enough for 2 or 3 patients for very little, and we can show you how to use it. It saves the patients a lot. Technician, unfortunately, it's not available except in Markaz Bahia and Ma'had al-Awram because of the cost and availability of the technician and so on. Ideally, use technician and blue dye, but blue dye assisted sampling is very accepted. If you don't have blue dye or technician and you don't want to practice them, sampling is very good if you learned how to. And we are prepared, please, Dr. Tahir, to arrange workshops whenever you want, wherever you want, and we would love it to go back to the old days of 2013 when I used to visit you. Whenever try to do a sentinel node, try to get the number between 3 and 5. Can we do it after neoadjuvant therapy? That needs another lecture, because yes, we can do it once you are trained in using it without prior chemotherapy. You will master it. Yes, you can start doing it after neoadjuvant therapy, but you need to learn first to do sentinel node on people who have not had prior chemotherapy. Let's just make a little sense about the lymph node management, differentiate between clinically involved axilla and clinically negative axilla. Clinically by hand and ultrasound. What do we see in ultrasound? We comment about the cortex and the hilum. Usually cortex more than 3 millimeters is a suspicious lymph node, and the thicker the cortex goes, the hilum becomes effaced, and that's a very significant sign on ultrasound scan. So always beg your ultrasonographer or radiologist, please comment properly about the axilla. Don't just tell me suspicious, benign, non-specific. Tell me the thickness of the cortex and how the hyaline is phased or preserved. Any suspicious lymph node should have an FNA prior to any surgical intervention. You need to know, because if it is positive, do I really need to do a sentinel node? I've already known, then you can proceed straight to clearance. But if the FNA is negative, then fair enough, you will proceed with sentinel node. So you really need to beg your radiologist, please do a proper assessment for the ultrasound. You need to know before you take the patient to theater, clinically positive axilla or clinically negative axilla. If it is proven clinically positive axilla, you go straight to level 1, level /2 clearance, or what I call it 1.5. If clinically negative axilla, then you're going to do a sentinel node. Do I need to proceed to clearance or not? We'll talk about it when we talk about discuss axillary management in the future. Right, just little examples here. If you have a tumor less than 50 millimeter, ER positive and will have post-surgery radiation and will have systemic therapy, at least chemo or possibly at least hormone because she's ER positive, or chemotherapy, and no extracapsular invasion. Sentinel node is enough. As long as only less than 2 lymph nodes involved. This is the Z11 study. We're going to touch it in details when we talk about sentinel node management. I'm just today trying to show everyone that is a very big spectrum. It's a beautiful, it's like game of, I would say, chess or shatterang. It's beautiful management. So I'm just running everything today for you. Levels. You really do need to do level 2, 3, 1, or so. You mainly get to do level 1, which is outside the picturesque major and under the axillary vein. Taking a couple of nodes behind the picturesque minor, you say I've done level 2. Going up toward the clavicle medial to the picturesque minor is a very dangerous act, and be careful, don't do it. Unless you are very experienced, and we do it only for the purpose of demonstration. So take home message today is good management plan is very important. Knowing in advance, you've done all your homework and you know whether she needs chemotherapy definitely or not. Should I give it before or after? Will she need radiotherapy? I've already known. Then should I really do reconstruction or not? Then that's a management plan. Don't start immediately. Plan from A to Z and start executing the management plan. Don't compromise oncology clearance for the sake of the cosmetic outcome, because that's not very good. Please, oncology first and then the cosmetic. If you can get both together in a good mutual way, fair enough. But please, oncology is more important than the cosmetic outcome. Pay attention to the look, of course. Reduce post-operative morbidity by the deformities and axillary management to reduce the lymphedema, meticulous axillary surgery. For people over 70, really be very gentle on their axilla. If they have clinically node negative axilla and possibly they are ER positive, even sentinel node might not be enough in these cases, and you can answer questions about it, because I'm just inciting now questions when I say that. Differentiate between clinically involved and clinically negative from prior assessment. Level 3 clearance is obsolete, does not add anything, it's pretty dangerous. Sentinel node and sampling is the standard. Axillary radiation as a definitive management is very accepted. So I will answer again my first question. Our breast cancer management, is it really a surgical or a medical? Without surgery, absolutely no survival. But with medical oncology, we can improve survival. That was just a run over the subject of breast management, but not all about cancer. We're going to talk about benign diseases and potentially malignant diseases, but it was just a run over what is breast surgery. I think I gave you a headache. I'll stop here, and people are invited, Dr. Tahir, to come in.
Okay.
شكرا دكتور أشرف. حقيقي يعني وحشتنا ووحشنا كلامك الجميل ده، ومحاضرة أكتر من رائعة طبعا كالعادة، متألق دائما. ربنا يجعله في ميزان حسناتك. انا هسال بس حضرتك سؤال. التروكات والفاين نيدل اسبيريشن سيتولوجي، لو انا عندي سيست، السيست دي partially cystic partially solid، والسؤال الثاني ايه هو المينيمال سايز للتروكات؟ يعني لو عندي تيومر السونار قايل ان هو حوالي 2 ل 3 مللي، 2 3 مللي، انا بالتروكات مش عارف هقدر ادخل فيه او لا، فهل في مينيمال سايز حضرتك تفضل فيه الفاين نيدل، ولا اعمل لها اكسجن بايوبسي وخلاص لو هي 2 مللي 3 مللي؟ يعني لغايه امتى الاكسجن بايوبسي ما ينفعش يتعمل للتيومر؟
طيب انا هقول بس الاف ان اي when you have a cystic lesion with a solid component in this, actually even if you take a core biopsy, because now you're suspecting intracystic papillary lesion. Whenever we talk papillary lesion, core biopsy will always be indeterminate and will never tell you benign or malignant. So whenever you suspect a papillary lesion, that area has to be excised, because we have 4 potentially benign diseases, yet they are potentially malignant. And I'm going to talk about it in the future. What are they? We have a radial scar. This is radiological finding of some disruption on the X-ray. We call it radial scar. That could mimic cancer, or cancer can mimic this. And that once you get that radiological diagnosis, the core biopsy saying radial scar has to be excised, sclerosing adenosis has to be excised. Papillary lesion, you will never get on a core biopsy a differentiation between benign and malignant, and that has to be excised. And of course, ADH, atypical ductal hyperplasia, because 50% of the time it will be the edge of a more serious disease, sclerosing adenosis, radial scar, and papillary lesion. So papillary lesion has to be excised. Core biopsy, unfortunately, will not make a difference. So you do an FNA, aspirate the cystic component, but if on ultrasound scan you still see the solid component, it is excision, not a core biopsy, because core biopsy will not differentiate papillary from benign cancerous papillary lesion from a benign papillary lesion. Before I talk about a core biopsy, I always say I am as good as the radiologist and pathologist working with me. If you have a good radiologist, your results will be fantastic. If you have a so-and-so radiologist to modify your work, before I get into this, you can do hand-free in your clinic, where you can feel the tumor easily. It is relatively superficial. It is over 2 centimeters. Yes, you can do hand-free biopsy, but make sure she had the mammogram and ultrasound scan first, because you are going to get a hematoma. When she gets a mammogram, it will hurt her, and the hematoma, which will develop after the core biopsy, will distract or disrupt the image. So get the mammogram and ultrasound first. Yes, you can do a hand-free core biopsy for a tumor that's superficial and over 2 centimeters if you can feel it easily. Regarding what is the smallest size, you are as good as the facilities you have with the radiologist. High resolution ultrasound scan can show the smallest lesion very well, and yes, they can take a core biopsy. But if your radiologist say, I'm sorry, it's too small for me to take a core biopsy, then you have no option but to have a wire and the excision, plus or minus frozen section, to determine what you're going to do for the axilla. So you are as good as the radiologist. If he tells you, I cannot biopsy it, then he cannot biopsy it, and you're going to go for a wire-guided excision. But if he tells you, yes, I can, then that would be the best, because you really don't want to do excision, and then you see the patient a week later, it proves to be cancer. You're going to take her back to theater for nodal assessment. So again, frozen section in Egypt, I love it, but I don't do it for reasons that will put me to prison, in prison if I talk about it now. So no, I don't use a frozen section. So you are as good as the radiologist working with you. But the idea to get the maximum information before you go to theater. I don't know whether I answered it, Dr. Tahir.
شكرا دكتور اشرف ليك. لو في حد عنده اسئله يا اخوانا الاطباء.
حضرتك رافع ايدك. دكتور لملوم.
ايوه، السلام عليكم ورحمه الله وبركاته.
عليك السلام يا دكتور لملوم، ويعني ألف سلامة عليك، وربنا يكرمك ويرفع قدرك ويرفع عنك.
ربنا يحفظك لينا ويزيدك علم ويحفظك لمصر كلها. أنا ممنون جدا، وبصراحة يعني دي محاضرة قيمة وربنا يجعلها في ميزان حسنات.
الله يخليك. ده يعني هقول بزغزغ كده بس يعني، لكن احنا طلعنا منها ان محتاجين 10 محاضرات تانية، وانا جاهز كل يوم.
ربنا يحفظك يا رب ويزيدك علم. سؤال صغير. الالترا ساوند جايدد كور بايوبسي، يعني هل it is يعني accurate or not؟
You are as good as the radiologist working with you. انت بقدر ان الراديولوجيست بتاعك كويس انت كويس، لانه if he missamples the patient really will not get properly diagnosed. You are as good. عارف دكتور لملوم، you have to nag your radiologist. You need to improve him if you want to improve. If you want yourself, your practice to be perfect, you've got to keep nagging your radiologist. Why didn't you say that? Can you do that? Whenever you get a report in your clinic, call him. Why did you say that? Can you do that? You are going to force him to read and improve and improve. So to bring him to the level you really want. So yes, it is more accurate than hand-free because it's guided. And you can take a photo while they are firing the needle. They take a photo to show you that the needle was inside. That's for assurance. Yeah.
Thank you very much.
It's much more accurate than hand-free.
I think all palpable masses can be done in outpatient clinic.
Yes, provided they are superficial and provided you've had proper ultrasound and mammogram, you can do it. Everywhere in the world, whenever I'm in an international conference or whatever, we have that good facility, ultrasound guided. But of course, when you have a patient with a fungating, ulcerating tumor, you really want to send it to the radiologist. But when you have tumor that's smaller than 2 or 2.5 centimeter with a big deep in the breast, I highly recommend ultrasound guided, because we have seen the needle as it goes in some solid tumors, Dr. Lamloum, sometimes it does that, it skips, sometimes it does that. Plus, once you have the first fire, you're going to get a hematoma. When you take a cord biopsy, you take 3 to 5 passes. Why is that? Because tumor is زي الرخام. It could be areas darker than others, and you have to make sure you got from everywhere. When you do hand-free in a relatively small tumor, smaller than 2 centimeters, and you get a hematoma, after that, it becomes difficult to sample the rest of that tumor. While when you're doing an ultrasound scan, the ultrasound scan will always show you the solid component, regardless of the hematoma, and you'll be able to sample again and again and again. So it's always more important, better for a relatively small tumor, smaller than 2.5 centimeter, to insist on ultrasound guided.
في سؤال من الدكتورة سلوى بتسأل الفايبرو ادينوما، الالترا ساوند بنت 18 سنه عندها فايبرو ادينوما، الالترا ساوند قايل انها بيرد 3 فايبرو ادينوما، هل هتحتاج ترو كات نيدل بايوبسي ولا لا؟
Under 25, yeah, the indication for I was going to talk about it in the future, but for a fibroadenoma, the indication for excising a fibroadenoma, usually patient wish bigger, for me, bigger than 3 centimeters. Dr. Tahir, Dr. Lamlou might decide 4 centimeter is my threshold, 5 centimeter, 2 centimeter. My threshold is 3 centimeter. Fast growing fibroadenoma increasing by 50% every 6 months. So it's a patient wish, more than 3 centimeters for me, or fast growing, or any fibroadenoma with a strong family history of breast cancer, I am going to excise. do I need a core biopsy of this for a patient under the age of 25? If clinically and ultrasound agreed that it is benign, I am prepared to go straight for excision. But if she is over 25, I am not going to proceed without a core biopsy first. Why is that? Just remember the risk factors in breast cancer. The main risk factor for breast cancer is being a woman, because 1 man to 100 women. Number 2 is getting older. The risk of developing breast cancer goes up with the age. From 20 to 30 is 1 in 2,000. From 30 to 40 is 1 in 200. From 40 to 50 is 1 in 50. From 50 to 60 is 1 in 24. Over 60, between it and 70, is about 10%, about 1 in 10. So as we grow older and we get close to 30 or past the age of 30, the risk grows from 1 in 2,000 to 1 in 200. So core biopsy here will become mandatory. We all fellow vet. I have had a patient with 21. She was from Mansoura. She had a tumor. It's a really big, clear-cut fibroadenoma. I did not take a core biopsy. I excised. To my surprise, it came back as cancer. I had a patient in my clinic recently. She was 24. She was pregnant. During her pregnancy, she went to a medical oncologist, famous in Egypt. I will not mention his name. He's a friend of mine. And he said, don't worry, that's just a prominent gland, a bit of milk, blah, 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 leave it and come back when you've given birth. ولدت بترضع اللمبة عمالة تكبر ضعفت حجمها راح لها قال لها come on, don't worry about it. في الآخر البنت insisted إنها تعمل لها كور بايوبسي, came back as cancer. قال لها شوفي حظك بقى البناين تحول لمالجنت وكده. فيعني it is very sad طبعا. any patient with a family history of breast cancer, the lump is growing, she's over 25, I insist on core biopsy. Under 25, with no family history, ultrasound and clinically agreed that it is benign, you might not need a core biopsy and go excise if it is more than 3 centimeters, if it is fast growing one, or if she has a family history, and respect a patient wish. Because she takes it to bed every night with her and could be very preoccupied with it.
شكرا يا باشا. دكتور
شكرا بس الله يخليك دكتور شكرا دكتور اشرف على المحاضره الرائعه دي. بس هو للاسف الصوت كان في بعض الاحيان مش كويس، فكنت عايز اسال هل الراديو ثيرابي كان سبستيوت الاكسيلري كليرنس كومبليتلي ولا ايه؟
بص حضرتك one of the biggest studies شغاله دلوقتي اللي هي الالاينس ستادي، but انا هقول لحضرتك على المانجمنت اوف ذا اكزيلا. احنا رجعنا ل 1970s اما برضه there are landmark studies in breast management. One of them is very important. I still remember it very well. I insist on mentioning it. The National Surgical Breast and Bowel Project, 004. جابوا فيها مجموعة من المرضى clinically negative axilla. قال لك تعالى نشوف المرضى دول نعمل لهم ماستكتومي and axillary clearance، ومجموعة نعمل لهم ماستكتومي with no axillary clearance ولا radiotherapy، ومجموعة ماستكتومي and radiotherapy للأكزيلا. السرفايفل هو بعد 25 to 30 years، مع ان في المجموعة اللي اتعمل لها clearance كان 17% منهم عندهم positive nodes. يبقى المجموعة اللي اتثبت الأكزيلا بتاعتها 17% منهم عندهم axillary nodes، والمجموعة اللي أخذت radiotherapy للأكزيلا 17% أكيد had positive nodes. السرفايفل هو. So that was very important study. In recent أما اتكلمنا على Z11 اللي هي بدأت سنة 1999 قفلوها 2004 وأعلنت الريزلتس 2011. قال لك up to وأنت بتعمل sentinel nodes up to 2 lymph node positive with no extracapsular invasion, no need for further management الأكزيلا، لا radiotherapy ولا clearance. إنما لو لقينا more than 2 lymph nodes involved أو كان في extracapsular invasion, you need further treatment للأكزيلا. Should I do clearance ولا radiotherapy؟ فجت هنا الستادي بتاعت أمارس اللي وقفت أو اتقفلت خلاص 2014 أو أعلنت الريزلتس بتاعتها 2014 تكمل الزد 11. قال لك في السنتينل نود up to 2 خلاص ما فيش further management. طب more than 2 تعال نجيب مجموعة نعمل لها clearance ومجموعة نعمل لها radiotherapy. لقوا المجموعة اللي اتعمل لها radiotherapy better survival, better morbidity أو less morbidity better good control, better than getting axillary clearance. So hang on, yes, radiotherapy can substitute axillary management. Whenever I get a patient who's over 70, has loss of morbidity, she is on anticoagulants, I don't touch their axilla. Even sometimes they have positive axilla clinically. We don't touch them, and I rely on radiotherapy for them, and they do very well. So yes, can substitute, but you have to differentiate between from the very beginning, clinically positive, there is nothing saying radiotherapy will substitute. You go for clearance unless you have a reason. She's over 70, it's a small tumor, blah, blah, blah. You can even omit the axilla altogether or give it radiotherapy if it is positive. Yes. So it can substitute in selected cases. Yes. I don't know that I covered it, Dr. Faiz.
Yes, دكتور أشرف. Yes. في سؤال من اتفضلي يا دكتورة زهرة.
الدكتور احمد قطب رافع ايده بقاله فتره.
طيب اوكي ماشي، اتفضل يا دكتور احمد.
احمد.
اتفضل يا دكتور احمد قطب.
طيب في سؤال
دكتور أشرف.
السلام عليكم يا دكتور أحمد.
السلام عليكم يا دكتور أشرف، كالعادة طبعا أنت رائع يعني، ووحشني جدا أولا. الله يبارك فيك. Just I want to ask about how do you manage phylloid tumor?
في وقت ولا طيب. You take a core biopsy, you have a tumor that is behavior has been surface بتاع irregular, usually bigger than standard fibroadenoma. You take a core biopsy and then you get a good pathologist to tell you about it. What it is it malignant phylloides or borderline phylloides or a benign phylloides? You go and treat accordingly. If it is a malignant phylloides, it's mandatory to get a good margin, minimum 10 millimeter. If it is a malignant, on the core biopsy, it's a malignant phylloides, the margin, because the first treatment is the best treatment. Any recurrence is a killer. So you need, if the core biopsy tells you it is malignant phylloides, you need a good margin, minimum 10 millimeter. Don't touch the axilla. Less than 4% of malignant phylloides will have axillary involvement. So the standard is, unless they are really big, don't touch the axilla in a phylloides. We don't usually give them adjuvant chemotherapy or radiotherapy, but you stage the patient and you only give chemotherapy if there is distant metastasis. Otherwise, there is no adjuvant treatment for malignant phylloides. It is excision with a 10 millimeter margin. Don't touch the axilla, no chemotherapy or radiotherapy. When you get a recurrence or metastasis, then you treat the metastasis with chemotherapy, and you can treat the local recurrence with excision plus radiotherapy because they are not very radio or chemosensitive. That's for a malignant. For a borderline, you still aim at 10 millimeter. For a benign phylloides, the problem with the benign phylloides, when you see it, it will depend on the age of the patient. If you have a patient with 21, 22, is not married or she's engaged almost above her breast. If you go in here for a 10 millimeter margin, you actually done a mastectomy for this patient. So you might accept a smaller margin for a benign phylloides, knowing that yes, there will be a chance of local recurrence, but you have to weigh, do I really want to do a mastectomy for a patient whose wedding is coming soon, is involving her breast, it's a mastectomy. You might here go for a minimum 1 or 2 millimeter margin, but make sure you excise the capsule completely and watch this patient with the first recurrence. You go in back in again for further management. So again, for the benign, your management depends on the size of the tumor in relation to the breast and the age of the patient. But for malignant, there's no compromise. It is a 10 millimeter margin, no nodal surgery, no radiotherapy or chemotherapy.
شكرا.
ربنا يكرمك.
دكتورة زهراء، في حد عنده رافع ايده وحد هيسأل او حاجة؟
في سؤال على الشات بوكس مكتوب what is the number of lymph node should be at axillary clearance when we should have excise fibroadenoma. أظن دكتور أشرف جاوب السؤال ده.
أجاوب على number of lymph nodes. When we talk sentinel lymph nodes, if you use technetium or blue dye or both, you have to remove the hot for the technetium and the blue with the blue dye, whatever number they are, 1, 2, 3, 4, 5. Any blue node, any hot node has to be excised, but always aim at 3 to 5 lymph nodes, because that increases the accuracy and reduces the false negative. So we always aim, if you remove, you found only one blue or one hot, try to put your finger and any hard or large node, also pick it up as well, cherry picking the hard and the large on top of the blue or the hot, whatever number that is, but always aim at 3 to 5. That's for sentinel node or sampling. For axillary clearance, there is nothing called what is the ideal number, because when you go for clearance, you have boundaries. We know the axillary level 1, here's the pectoralis minor, here is the axillary vein, everything outside them is a piece of cotton, حتة قطنة مرصعة بغدد، انت ما بتعدش غدد، انت بتشيلها وبتبعتها للمعمل، المعمل هو اللي بيفتحها. and if you've done a proper level 1 clearance، المعمل بيديك always من 13 ل 19. بس خد بالك لو المريضه دي كان معمول لها نيو ادجوانت كيموثيرابي قبل كده، يمكن تفاجئ ان المعمل بيقول لك 4 و5 و6 نودز بس اللي لقيناهم، لان الكلينيكال او الريسبونس للليمف نودز احيانا ان هي بتتحول لفايبرس تيشو لدرجه ان المعمل ما يتعرفش عليها على ان هي ليمف نود. فاحنا ما بنعدش ليمف نود يا دكتوره، احنا بنشيل حته القطنه اللي متعلقه بين البيكتوريس ماينور والاكزيلاري فين، بتتشال كلها وتروح للمعمل، هو اللي بيفتحها وبيعد الليمف نودز فيها، usually from 13 to 19, 21, 26 if you pinched also the level 2 ones. So we don't count, you just remove that piece of cotton معلقة بين الماينور والأكزيلاري فين.
يعني كده خلاص ما حدش عاد بيعمل ليفل 3 ولا بيعمل كلاس ماينور كات ولا الحاجات دي.
انا بعملها only for teaching يعني for teaching purpose، او ان انت احيانا بتحب تشو اوف كده شويه يعني تدلع كده، انما لانها it adds nothing. حضرتك اي اكزيلا حتى لو فيها one lymph node positive is going to be hit with radiotherapy بعد كده deliberately. فirradiating the axilla now is a standard whenever you found single lymph node positive. So Dr. فايز من شويه كان بيسال can it substitute؟ Yes. ما احنا سايبين ليفل 3 واحنا نعرف ان غالبا في positive nodes بس هنعالجه بالريد. So it does not add anything to go for level 3. It's dangerous لان حضرتك عشان تخش ميديا للبيكتوريس ماينور when you are not really expert وانت عارف الاكزيلاري فين في الحته دي بيبقى very hash. فانا بعملها فقط once in a while اما بحب اعلم some of my younger colleagues يعني، فبوريهم ازاي تعمل الموديفايد بيتي، تقطع الماينور وترفلكت داون وتخش وتبي careful just for teaching purpose. انما does not add، لان هتاخد radiotherapy which will be a good substitute, safer substitute زي ما الدكتور فايز قال.
الراديو ثيرابي بعد قد ايه بالظبط من يعني احول العيان قد ايه بوست اوبراتيف للراديو ثيرابي؟ لو انا خدت ليفل 1 زي ما حضرتك قلت، خدت ليفل 1 ونزلت بعد البكتيرياس ماينور وخدت معاها الايه كل الليمف نودز فيها، حولها بعد قد ايه؟
بس يا دكتور دايما النكست ستيب اوف مانجمنت should be done within 35 days from the step before it. فلو انا هعمل جراحه والمريضه هتحتاج كيماوي، البرايورتي الكيماوي قبل الراديوثيرابي should be given within 35 days from the surgery. I finished chemotherapy should be done within 35 days. Radiotherapy should start within 35 days from the chemotherapy, which was the step before. So التسلسل is surgery, chemo, radio. طب انا مش محتاج كيمو، يبقى the next step should be done within 35 days from the step before it, but never before 2 weeks. لان احنا عارفين الcomplication, especially infection, will show itself within 14 days, and you definitely don't want to give this patient radiotherapy when there is infection in the wound, ولا حتى chemotherapy طبعا. عشان كده بتشوف المريضه يمكن بتجيبها اول اسبوع تشيل لها الدماغه، بتشوفها بعد اسبوع ثاني اسبوعين من الجراحه ما فيش انفكشن، بتحولها للميديكال اونكولوجيست او الراديشن اونكولوجيست. فدايما كل step should be done within 35 days from the step before it. Having said that, الراديوثيرابي بالذات is a bit of an exception. استثناء. يعني ايه اقصد استثناء؟ There is benefit from radiotherapy even if it is delayed up to 6 months. ما انا بجيب البيشنت بعمل الجراحه اسبوعين حولتها الميديكال اونكولوجيست، قعدت 4 ل 5 شهور بتاخد كيموثيرابي، ومش طبعا ما اقدرش، الكيموثيرابي ملوش شريك، يعني الكيموثيرابي يبقى كيموثيرابي، ما اقدرش اخش معاه لا هرمون ولا اي، اقدر بس اخش معاه بهرسبتين، لكن ما اقدرش اخش معاه لا راديو ولا هرمون. وده هياخد 4 ل 5 شهور مع اسبوعين قبلها اللي هي الجراحه احنا almost 6 months. فتعمل الدراسات عشان تشوف هل لسه بعد 6 شهور هيكون في benefit from radiotherapy؟ فقال لك yes up to 6 months there will be benefit still from the radiotherapy. فاما تجيلي مريضه مش هتاخد كيمو وبعدين عاوزه تسافر امريكا الساحل تتفسح وكده وبتقول لي ممكن اجله شهر او شهرين، yes في الراديوثيرابي ممكن، although لتنظيم المرور ideally next step should be within 35 maximum 40 days. But for radiotherapy بالذات there is benefit up to 6 months.
دكتور وليد محمد عنده سؤال.
السلام عليكم دكتور اشرف، ازي حضرتك؟
وعليكم السلام ورحمه الله وبركاته. دكتور وليد ازيك؟
ازي حضرتك؟ وحشنا كتير والله، ربنا يديك الصحه ونفضل نسمعك كده على طول. انا كان سؤالي لحضرتك بس يعني الريسك في بوست ماستكتومي ليمفيديما increased with radiotherapy after axillary clearance or does not affect the risk of lymphedema?
It does. After you mean after axillary dissection.
يعني انا حضرتك بتقول ان احنا not the need for group 2 or group 3 clearance.
Yeah.
We can do radiotherapy, auxiliary radiotherapy.
To supraclav, infraclavicular, and if more than 2 lymph nodes, axilla as well. Even if you have a single lymph node here, they will have radiotherapy to the
لا انا حضرتك عملت auxiliary clearance وحضرتك بتقول ان انا مش لازم اعمل ليفل 2 ليفل 3. ممكن ادي auxiliary radiotherapy.
ما هو دكتور وليد any positive axilla whether انت عملت level 1 ولا 2 ولا 3 if you have a single lymph node positive she is going to have radiotherapy to the axilla. When you if you have axillary lymph node involvement, even if it is one, that means whether you did a mastectomy or you did lumpectomy, she is going to have radiotherapy to that chest wall, and the tangential field will always hit level 1 for you. So whether it's 1 or 2 nodes, that level 1, you like it or not, is going to be hit with radiotherapy from the tangential field to the breast. But if you have more than 2 lymph nodes involved, most radiotherapists are going to irradiate as well the infraclavicular and the supraclavicular deliberately here. So whether you do clearance to level 3 and then add to it the damage from the radiotherapy, give a double risk from the surgery as radiotherapy or not, yes, it will always increase the risk of double the risk possibly of lymphedema, but it's all about disease control.
تمام، شكرا لك.
احنا نحاول نسيف ال 70% اللي هم have no negative، نحاول هم دول اللي نركز عليهم نسيف ذي الفكره، بس المجموعه اللي هتطلع بوزيتيف اكزيلا and هياخدوا راديوثيرابي ما here is a disease control.
كده دكتور اشرف يبقى السنترال ليمف نود لو انا لقيت سنترال ليمف نود
شكرا جزيلا
واحده او 2 كده اعمل بس ليفل 1 وخلاص على كده.
ما هو اتفقنا يا دكتور طاهر. If the patient before you take her to theater عملت assessment clinically and radiologically and she is node negative clinically بالالتراساوند وبايدك she's node negative، ساعتها انت هتعمل central node and stop no further surgery. وبعد كده هتشوف السنترال نود بعد اسبوع طلعوا كام واحده positive up to 2 lymph nodes positive, no need to take the patient back to theater. ولا حتى تاخذ radiotherapy. But more than 2 lymph nodes were involved مع sentinel node ما ترجعهاش العمليات تاني، اديها radiotherapy للاكزيلا. So اتفقنا ان هو الكونكلوجن clinically negative axilla قبل العمليه، clinically negative بالالتراساوند بالاف ان اي بايدك. All you need is a sentinel node and stop. If a week later get like a result in up to 2 lymph nodes positive, no need for further treatment للاكزيلا. But more than 2 lymph nodes positive, you need further treatment للاكزيلا. تسال بقى نفسك radiotherapy ولا رجعها تاني clearance؟ لا radiotherapy تبع AMARUS study is better than further surgery. So clinically positive axilla, you're going for clearance level 1/2. If it is clinically negative axilla, just sentinel node and stop.
دكتور محمد جمال،
تمام.
ده آخر سؤال بقى إن شاء الله. احنا عارفين تعبنا حضرتك النهارده. دكتور محمد جمال. دكتور محمد جمال please unmute.
ايوه.
اتفضل يا فندم.
السلام عليكم دكتور اشرف، ازي حضرتك؟
ازيك يا محمد؟ ازيك؟
اخبار حضرتك يا فندم؟ محاضره جميله والله.
ربنا يكرمك يا محمد، ربنا يكرمك.
انا بس كان سؤالي يا فندم على في سؤالين. سؤال حضرتك جاوبت عليه في السؤال اللي فات بتاعت الاكزيلري اللي هو كده وكده هناخد راديو ثيرابي بعد الاكزيلري دايسكشن. هل في حالات ممكن ما ناخدش فيها راديو ثيرابي بعد الاكزيلري دايسكشن طلعت فيها بوزيتيف نودز؟ ده اول سؤال. والسؤال الثاني البادجت، مانجمنت اوف بادجتس.
طيب لا ده باجي ده احنا هناخد سيريز، فمش عاوزين نتطرق للديزيز لان لازم ان شاء الله هنعمل محاضره all about special types of pages for inflammatory breast cancer, invasive lobar, cancer in pregnancy، الحاجات دي كلها we need a day خلي الباجت معاهم. لكن هرجع اقول هو ينفع اعمل اجيلا وتطلع بوزيتيف وما تاخدش راديو ثيرابي؟ ما هي البرنسبل if you have positive if you have a positive axilla. انا حد سامعني غير محمد؟
احنا
سامعينك كلنا يا دكتور، احنا سامعينك كلنا ولا هنفصل عن الدكتور محمد. كلنا سامعينك كويس.
التسجيل هيبان ان شاء الله.
indications يا دكتور محمد.
هي متسجله دكتور اشرف، حضرتك اتكلم وهو ممكن
دلوقتي انا سامع حضرتك والشبكه عندنا اللي بتقطع شويه.
طيب the indication ان انت تدي radiotherapy after surgery is لو عملت breast conservation regardless of the lymph nodes you are going to irradiate the breast. When you irradiate the breast level 1 because of the tangential field بياخد a touch. طيب انا عملت mastectomy او lumpectomy وطلعت positive node itself حتى لو عملت mastectomy is an indication for chest wall irradiation and level 1 is going to be touched. خلاص؟ لكن هنا يفرق معانا النمبر اوف lymph nodes. 2 or 3 lymph nodes, then you are going to go up to the supraclavian and infraclavicular. But one node you can تتخانق زي ما انت عاوز مع الراديشن or adamant انه هو حتى لو single node في الاكزيلا طلعت positive we have to irradiate الاكزيلا. Hang on, this patient is going to have radiotherapy to the breast or to the chest wall because she has positive nodes. الفيلد كده هياخد معاك level 1 شئت ام لم تشاء. ف you will not avoid it. Unless طبعا you have a patient who is 79 or 80 and can hardly walk والمريضه تعرف لو بعتها الراديشن انكولوجيست والمريضه ما تقدرش تمشي لوحدها unsupported no matter what you will not irradiate her. فالهيلث بتاعت المريضه برضه will have a saying.
في حد عنده اي اسئله ثاني؟
شكرا دكتور اشرف. شكرا
دكتور محمد.
شكرا يا دكتور اشرف، ربنا يكرمك ويجعله في ميزان حسناتك. يا دكتوره زهره في حد عنده اسئله؟
لا انا سؤالي انا المحاضره الجايه ايه ان شاء الله؟
انا هسيب دكتور طاهر يقولها. we can يعني do you want straight to go for interesting types of surgery ولا talk about the axilla because it needs lecture ولا we go for special types of breast cancer and we start to kind of يعني نقسم diseases لان انا دايما اقسم الديزيزز benign potentially malignant pre-malignant malignant and we touch كل واحد وبعدين نروح متكلمين special types. I think that could be interesting for people.
احنا لو سمعنا في فيديو من حضرتك للباتي او لل موديفايد راديكال او الحاجات اللي حضرتك بتعملها يعني فيديو كده وشرح عليه، برضه حاجه كويسه كلنا نستفيد من حضرتك، بس تكون حاجه حضرتك مصورها كويس ليك يعني يكون فيديو حضرتك مش مصوره فور تيتشنج، على اساس ان معانا جونيورز مثلا ما شافوش الاوبريشن دي كتير يعني.
انا هقلب السؤال عليك يا دكتور طاهر. why don't you arrange a workshop
احنا we are arranging already before corona and within 1 month ان شاء الله باذن الله we will arrange for this
workshop different types sentinel node and auxiliary clearance، وحتى واحده نوري الليفل، نوري كل النودز والimportant structure في الاكزيلا. we can arrange a list that كده we can videotape it and do it. Yes, definitely.
خلاص we will arrange for this workshop and
most الفيديوز اللي عندي بتاع حاجات reconstruction ترام ال دي كده، ما عنديش فيديوز بتاعت اكزيلا.
Let us arrange for this workshop and we will prepare the patients which we need to see their operations.
إن شاء الله. أما بالنسبة للمحاضرة اللي جاية I think we can go hit straight now. Let's talk about surgery and what types. لأن لازم ما نغفلش إن إحنا كجراحين not everything is cancer. We have benign diseases that really need good proper attention. So I think I'm going to talk about breast disease in general, benign, potentially malignant, pre-malignant, malignant, and then we branch from there, and then we can talk about special types, lobular in pregnancy, inflammatory breast cancer, and Paget disease, as Dr. Mohammed asked. Yeah.
Okay, Dr. Ashraf.
I'm prepared whenever you want me, weekly, bi-weekly, whenever it is. It's always my pleasure to give any experience I have to all my great colleagues. Yeah.
Okay, we will arrange the time with you and with the participants. Okay. شكرا دكتور أشرف، ربنا يكرمك.
We see the feedback and I'm ready whenever you want.
إن شاء الله بإذن الله. شكرا على الكلام، المحاضرة الرائعة بتاعت حضرتك دكتور أشرف، وربنا يجعلها في ميزان حسناتك إن شاء الله. شكرا يا باشا. شكرا. السلام عليكم ورحمة الله وبركاته. السلام عليكم.